Hello, everybody. Thank you for joining us here today. My name is Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation. And since the beginning of the pandemic, I've been hosting Facebook Live twice a week, Monday and Fridays, 1 p.m. Eastern Time. And I'm bringing specialists, researchers, healthcare professionals, parents from all over Canada to share with us their experiences, their knowledge, and answer parents' questions and concerns during this time. And today we are going to talk about a very important topic about bringing caregivers back into the hospital settings. And this week, Canadian Foundation for Healthcare Improvement just launched a report on the reintegration of family caregivers as essential partners in care. And to talk about this report, I have here with me Julie Drury, who was one of the authors, and she is a strategic lead patient partnership for the Canadian Foundation for Healthcare Improvement. Julie is passionate about the potential of patient, family, caregiver engagement, partnership, and leadership in health and healthcare. In her professional role, she facilitates and provides the patient-family perspective and supports frameworks and strategies for patient partnership in healthcare policy, system design, innovation, and improvement. As a mother of a child who was diagnosed with a rare form of mitochondrial disease, Julie has particular experience in system navigation, complex care, care coordination, palliative care, and patient safety. With over 12 years of experience as patient, family advisor, and leader, Julie is a sought-after speaker, panelist, and facilitator. She regularly consults with healthcare organizations, government, private sector, and not-for-profits on patient engagement strategies, patient partnership, and patient leadership. Julie, thank you so much for taking the time to talk to us here today, and welcome to our live.
It's great to chat with you, Fabiana. Thank you for inviting me.
So Julie, let's talk a little bit about where we were before this pandemic in terms of patient engagement and caregiver participation in healthcare in Canada.
Yeah, at the Canadian Foundation for Healthcare Improvement, Fabiana, we've been very interested in this topic for the past 5+ years. And we've worked quite closely with both partners across the country here in Canada, but also internationally. And most notably, 6 years ago, we started partnering with the Institute for Patient and Family Centered Care, IPFCC, in the United States. And they had a program, a campaign called Better Together. And this was very much about the role of family members or persons designated by the patient to partner in their care. So this could be a close friend, as I said, a family member, it could be a substitute decision maker, but someone that the patient said, I need them with me to make sure I'm safe in hospital, help me with my decisions, to support me both physically and emotionally. And so we started a campaign here in Canada 5 years ago in 2015, 5.5 years ago now. And at the outset, we studied 118 Canadian hospitals, and we looked at what their family presence policies looked like. And we were very careful, as you'll note, Fabiana, to distinguish between a visitor and a family caregiver. There's a very important distinction there, and we can talk about that later. We found across the country that 32% of hospitals had policies where family caregivers were welcomed to be present. In the other hospitals, we noted that there were restrictions around when they could be with their loved one or when they could be with that patient. Through our campaign over the last 5 years, we've been supporting hospitals, we've been partnering with provincial health authorities and with ministries of health to increase the understanding of that role of family caregivers. We've been working quite closely with many health authorities across the country. In January, February 2020, we did another look at the data. So we wanted to examine those 118 hospitals 5 years later to see where they were at. And we released our report, Much More Than a Visitor. And I can share that link so you can share it with your viewers. We found that 73% of hospitals across the country had adopted accommodating visiting policies. So that again was up from 32%. And we were really excited, and we were looking at what are the next steps here in partnering in care? What about having family members partnering in bedside rounds and family members partnering much more in transitions in care, such as discharge planning? So we were really excited for the future. And then COVID hit. And so we decided to do another data pull 2 weeks after COVID, when blanket visitor restrictions were put in place. Everybody was identified as a visitor. Didn't matter if you were a medical mom managing NG tube feeds or G tube feeds or managing central lines. Didn't matter if you're a wife who was helping to support your spouse in rehabilitation, moving around, supporting emotional health, looking at medication oversight. Didn't matter if you were a sister who was communicating with the healthcare team and supporting continuity of care, you were restricted. You were no longer welcome in the hospital. And so we went to 0%. We went down from 73 to 0 because of those blanket visitor restrictions.
Wow, that is something that obviously happened overnight, and it's understandable in the beginning because we didn't know much about the virus, how the virus spread in the community. And I feel that it was like it was very conservative to close everything, take everything out. So now, 4 months later, what can we do about this? Because now we know a little bit more about this virus. We know about the spread. We know the situation in Canada. And then you came up with this report to really assess the situation. So tell us about how this report came to exist, who was involved in the creation of this report, and what do you, let's talk about the report first and all the steps that you took, and then we can talk about the application of it.
Yeah, so the report itself is intended to be helpful. It's intended to be a guide and to offer suggestions about what next steps can be for provincial ministries of health, for health authorities, for medical officers of health, who are developing and implementing the guidance around family caregiver presence or visitor restrictions. And so we brought together what we called a rapid response advisory group. And I'm using the word rapid quite broadly. This report was about 2 months in the making, but that's actually moving pretty fast for a pan-Canadian organization. We brought together medical officers of health. We brought together CEOs of hospitals. We brought together people from provincial health authorities, frontline physicians and staff, persons who have legal expertise and expertise in bioethics and understanding the legal and bioethical implications of these policies. And of course, Fabiana, you know me well. I don't do anything unless I include patients, families, and caregivers with lived experience. So a third of our rapid response advisory group were people who were living in real time these policies. And that group was incredible, so generous with their time and with their experience and their expertise. And they were the ones who really helped to develop this report, to talk about this guidance where collaboration for patients, families, and caregivers in developing these policies was going to be essential. And then talking about what are some of the really tangible things that hospitals can do to support family caregivers coming back. Because you're right, at the beginning, this, of course, we're gonna lock it all down till we know what we're dealing with. But now 4 months in, we're continuing with a singular approach that is heavily emphasized on COVID and isn't looking at the other risks to harm for patients in the system. And one of those risks is not to have family caregivers present.
Absolutely. And sorry, Julie, there was a noise here. But so this report I read, and it's incredible. And you can really truly see the collaboration that happened, a multidisciplinary approach. And I think in Canada, we do have a good base. As you said, 73%, that is an incredible number of patient and caregiver present in hospitals with patients. And I spent 3 years with the Change Foundation, work on the caregiver project on the Sinai Health System side. And I saw like a very strong basis to bring a caregiver, identify the caregiver, all on co-design approach, which was incredible. So I think we do have good foundation in Canada to take this report and run with it in many areas of healthcare. So I want to share the screen now because you have this very good graphic that really summarized the report, Julie, and I would like you to guide us through and walk us through all those 7 steps for reintegration.
Yeah, thanks. And I apologize for the noise in the background. I've got a dog here who's wanting my attention. The fun of working from home, right, Fabiana?
We're all working from home, and maybe soon you're gonna hear my kids screaming.
So we went through these next steps repeatedly, over and over. And as you can imagine, with a group as large as 30 people advising on a project like this, there was a lot of, a broad range of what we were thinking about, and we brought it to tighten down to these 7 next steps. And really the first 2, I think, are foundational. And this is very much about ensuring that we maintain that foundation of what we call patient and family-centered care, or what I prefer to call patient and family partnered care. And I feel that we perhaps have lost that as our true north when we are facing this pandemic and this time of crisis. Family caregivers, patients need to be intimately involved when we're developing program and policy, and particularly when there's such a significant shift. They are going to be impacted by this. They're going to be living it, and they need to be there at the table. And we need to include our frontline staff as well, also heavily impacted by these policies. We've heard repeatedly at the Canadian Foundation for Healthcare Improvement about the moral distress of staff who are having to say no to family caregivers and who are struggling with how to support communication and continuity of care without the family caregiver present. So ensuring that foundation is our first next step, our first theme. Our second is revisiting these policies with family caregivers and patients at the table. And that's essential. And we've heard repeatedly from our large network of patients, families, and caregivers that we work with that that has not occurred. And so that is our first 2 steps of advice, is ensuring that that's happening. The third is what I alluded to earlier on. We need to distinguish between what is a visitor and who is a family caregiver. And so we are very clear in this report, offering very specific definitions. And you'll notice the hashtag we use for our report, more than a visitor. Mm-hmm. Visitors are people who are coming in for a casual visit. Certainly they likely offer some emotional support to the patient, but they are not actively engaged with the healthcare team, and they are not actively engaged in the care of that patient. And that's what a family caregiver is. And we use the family caregiver title broadly. Again, this means a family member designated by the patient to partner in their care, or a loved one or family friend, again, designated by the patient, a power of attorney, or a substitute decision maker, designated by the patient if possible, and where not possible, we're legally there or in that role. They are there to work with the healthcare team. They participate in support for the patient, actively supporting them either emotionally, psychologically, physically, and they are recognized by the care team. Oftentimes, and you'll see in the report, we ask them to actually be specifically identified, either through a name badge, accessing training, and being identified in the medical chart as a family caregiver. So that distinction is incredibly important. And unfortunately, Fabiana, I haven't seen that from any health authority, provincially, regionally, and in some hospitals, we're seeing the distinction being made. But the blanket visitor restrictions we've seen have been very much about visitors globally. So we need to make that distinction. The fourth step in our report is talking about who needs to be supported. Now, in the opinion of our expert advisory committee, all patients deserve to have that support of a family caregiver. But we have offered a list of specific patients, populations of patients that really do need to be considered. We've heard various stories of persons who have different cultural support requirements or needs, different language needs. In a very specific case in British Columbia, we learned about a young woman with developmental disabilities who needed the support of her caregiver and didn't have it. and unfortunately, she did pass away without the support of that loved one. And so British Columbia attended to that very closely and looked at changing their policies. But we can't wait those extremely challenging situations and tragic events to change this. We need to think about those patient populations where that support really is needed, and to do it quickly. We've talked quite a bit about taking a comprehensive and balanced approach to assessing risk. And so I mentioned earlier that in the early weeks of the pandemic, of course, a unilateral, very specific approach on COVID. But now we're recognizing that there are other factors at play here when it comes to patient care and patient safety and patient experience and their outcomes. And a significant part of that is the role of the family caregiver. This is evidence-based. We see this in the research literature. We have at least a decade of evidence about the important role and value of the family caregiver. So we cannot exclude that when we're assessing risk of excluding them. The rapid appeal process is something that came out of a few members of our advisory group where it's happening in their provinces or in their jurisdictions. And this is about if you are a family caregiver and you are being denied access and restricted from your loved one in hospital, who do you go to plead your case? And how quickly is that case or that situation heard? So we're calling upon hospitals, health authorities, or provinces, depending on how they want to structure it and depending on how the healthcare system is run in their jurisdiction, to establish a rapid appeal. And when we mean rapid, we mean 24 hours. If I'm a family caregiver restricted from care, I go immediately to a source that's been well communicated. I can see on the website, this is who I go to. Might be patient relations, might be another person in the organization. And I state my case and I ask for it to be reviewed. And so that situation isn't occurring for families. There's great confusion about who has the authority, who's accountable, who do I plead my case to when my loved one is vulnerable and suffering in hospital and I need to be partnering in their care. And the last part is really about the evidence. We are collectively making policy in a vacuum of evidence. We are treating, for example, families as significant vectors of transmission. In fact, to my knowledge, the most recent knowledge that I have, there's very little evidence of family caregiver transmission of this virus. And so with proper training, with proper support, similar to how you would treat staff, can we bring family caregivers back? And what is the evidence supporting the restrictions? And what is the evidence that would support returning them? And so we would like to see an increase in that evidence base and much more study and research about not just the value of family caregiver presence, which we know again is foundational, but about these restrictive visitor policies and the assessment of risk.
Absolutely. This is so important. Every single step of the way, I think is very important. And I think every area of healthcare can look at it, because we are talking here about obviously NICUs, and the situation in the NICUs were different than other areas of hospitals, as parents were not banned in Canada from coming inside the units, but definitely limitations were imposed because in some hospitals only one parent is still allowed to come in a 24-hour period. And some hospitals did not change the policies. I think there's a lot that we can learn from those units where they maintain the same parental presence in the NICU and didn't have a transmission from parents to staff, which was the main concern in the beginning, or transmitting to their babies who were already a fragile infant. So now, as you mentioned, 4 months later, there's a lot we can learn from other units, and maybe the NICUs could be a way to look at, as some hospitals did not change policies at all, and there was no outbreaks of COVID in those units. And I think every single step there, it's very valuable to every setting, including the NICU. Is it applicable to everywhere else, Julie?
When we developed this report, Fabiana, we were very much focused on hospitals and across the hospitals. So critical care, ICU, PICU, NICU, inpatient rehabilitation units in hospitals. I have been asked repeatedly about long-term care, and my response is that certainly these next steps and what we are talking about in this report very much parallel long-term care. It's a very different sector, but a family caregiver presence and that role in the care of a loved one is important across our healthcare system. In NICU, I'm so glad that you talked about this. We are looking at, in some instances, as you mentioned, one parent being allowed, in other instances, two being allowed. Sometimes it's they're able to take shifts. There's inconsistency across the system, and that causes distress. And it's not just inconsistency across the country, it's inconsistency across provinces and regions. Now, that might be a bit of the effect of what's happening in a particular jurisdiction in regards to COVID outbreak and COVID numbers. But we've got to be able to communicate that to family. And we have to take a reasonable approach of when things change and circumstances change, how do we bring family caregivers back quickly and efficiently? And how are we supporting them and training them? In the case of the pediatric settings, as I've mentioned before, here in Ottawa, where I am in Ontario, the example I'll use is the Children's Hospital of Eastern Ontario, CHEO. They have not had one case of family caregiver transmission of COVID. Highly powerful to know that. And again, we need to study that further and understand the implications of risk here before we apply policies without any evidence.
Absolutely. Julie, now we have this report. What has to happen? What is the call to action? Because I truly believe in collaboration. I don't think anybody's here to work separate or to, point fingers at anybody, but it's a true collaboration between caregivers, patients, and the staff.
Yeah, I'm so glad you said that. There's no room for blame and shame, especially in this time of COVID-19. Everybody is doing their utmost. Staff are doing an incredible job. Leadership are doing an incredible job. Governments are working so hard and around the clock. I mean, the dedication to this work is incredible. The call to action for me is to understand the issue and understand the issue broadly. And to ensure that there's collaboration as we're tackling this. We can't take a unilateral or a singular lens approach on this. That is not what's going to get us through COVID and supporting our patients well and our families well. This does require a collaborative approach. It requires an understanding of the evidence, and the evidence is clear about family caregiver presence. We have incredible knowledge out there in programs already about how we can support family caregivers. You mentioned the Change Foundation earlier, their caregiver ID program, where they've worked with hospitals very closely to support that role of family caregiver presence. We can leverage that. So let's be aware of the evidence. Let's be aware of what's available to us already in the system to support that family caregiver reintegration, and calling upon healthcare system leaders to take this collaborative approach to work with the patients, families, and caregivers to bring back family caregiver presence and to support those patients and the healthcare teams in the way they need to be through the pandemic and after. Let's embed family caregiver presence. Let's institutionalize it. Let's make it part of the healthcare system so that this fragility that we saw in this time of COVID-19, where we went from 73% family caregiver presence to 0 overnight, that doesn't occur again, where we can support it and where we can ensure that continuity in care for our patients across the system.
Absolutely. Julie, thank you so much for joining us here today and to share this amazing report. I'm really hopeful that we're going to move forward with this. And if there is a new surge in the fall, in November, we are prepared for that. So thank you, Julie.
Thank you, Fabiana. It's so great to chat with you and connect with you again. And just a shout out to all of your moms and dads out there, and sending them much love and hugs.
Thank you. And thank you everyone for watching us here today. Just a reminder, every Monday and Friday, 1 p.m., I'm hosting Facebook Live with different experts, healthcare professionals, parents from all over Canada. And if you have a suggestion of a topic, please send it to us. And all past sessions are recorded and available on our website, and you can access on CanadianPreemies.org. And every Wednesday, Kate Robson, who is a psychotherapist and also a mom of 2 preemie babies, it's hosting a real-time peer support group here on Facebook. And to access her group, you can join the Canadian Preemie Parent Support Network, which is our private Facebook group. Thank you and stay well.